This is a CT scan of the neck with intravenous contrast administration, and the abnormality is clearly seen here. To better understand the location of this abnormality, keep note of this bony structure, which is the mandible. In close proximity to the angle of the mandible, you're going to see this structure here, which represents the parotid gland. Let's compare this to the other side, where you see the angle of the mandible and this parotid gland structure that has a density that's intermediate between fat and soft tissue. As you notice here, there is a superficial component of the parotid gland, and there is also a deep part of the parotid gland. So back to the right-sided abnormal parotid gland, where you have a superficial part and a deeper part of the parotid gland. As we scroll lower down, we see this large heterogeneously enhancing lesion. These internal low density areas may represent cystic changes or necrosis. The lesion does not have clear calcifications, and there is no surrounding inflammatory change within the subcutaneous fat to suggest an inflammatory component. Now, the most common parotid gland tumor is called a pleomorphic adenoma, or another name is a benign mixed tumor. This is a benign tumor with a small potential for converting into malignancy. It's classically homogeneous unless it's big like what you see here. When pleomorphic adenomas are large, they might have necrosis. So our first option would be a pleomorphic adenoma or a benign mixed tumor, BMT. The second most common parotid gland tumor is called a Warthin's tumor. Warthin tumors are mostly seen in adult male patients around 50 or 60 years old who are classically smokers. It's a benign tumor, and in many ways it could be considered a hamartoma of the parotid gland. Although Warthin's tumor is classically heterogeneous, smaller lesions may be homogeneous as well. We don't have calcifications here, but if calcifications are seen, this would be very unusual for a Warthin's tumor and would favor a pleomorphic adenoma. We just said that Warthin's tumor is the second most common tumor affecting the parotid gland. However, when a lesion is seen in the parotid tail immediately superficial to the mandibular angle, Warthin's tumor becomes more common. Another feature which would favor a Warthin's tumor is multiplicity. 20% of these tumors are multiple in the same gland or in the contralateral gland. Minor salivary gland tumors such as adenoid cystic carcinoma and mucoepidermoid carcinoma could occur in the parotid gland as well. These minor salivary gland tumors are typically more aggressive and have an infiltrative appearance rather than a well-defined appearance, although overlap does occur. Now let's go to the contralateral side. This is the parotid gland on this side, and if you look carefully, you'll notice that there's a lesion here. This is a lesion that's slightly deeper in location within the parotid tail and abuts the mandibular angle. Multiplicity would raise the possibility of Warthin's tumor, metastasis, lymphoma, and sarcoidosis. Given the lesion on the other side being heterogeneous, this makes lymphoma less likely, since most lymphomas are homogeneous. The lack of a known primary malignancy and the lack of lesions elsewhere in the body argue against metastasis. Sarcoidosis is not totally excluded, however, more lesions would be expected in that condition, and it's a less common etiology. As we just mentioned a few minutes ago, this location is a very good location for Warthin's tumor. Now, if you take into consideration the patient's age, he's a smoker, has a heterogeneous lesion on the right, it's multiple with another lesion on the left side. This would make a Warthin's tumor the most likely consideration, which was confirmed by tissue biopsy from this abnormality. Remember, the most common parotid gland tumor would be a pleomorphic adenoma, also known as BMT. The second would be a Warthin's tumor, Minor salivary gland tumors are typically more infiltrative, and lymphoma, sarcoid, and metastases would be multiple. It is also important to remember that 20% of parotid Warthin's tumor are multiple, either in the same parotid gland or in the contralateral site. And heterogeneity is the rule with Warthin's tumor, while a homogeneous appearance is the rule with a pleomorphic adenoma. However, overlap does occur. Calcifications are seen with pleomorphic adenomas and would make a Warthin's tumor unlikely. Thanks for watching. There are bilateral ill-defined opacities. The opacities are cloudy in appearance, and this is what we call alveolar opacities. Another name for alveolar opacities is airspace opacities. The differential diagnosis for airspace opacities is long, and that depends on whether the patient presents acutely or chronically, and it also depends on whether the patient is immune competent or immune compromised. Describing the predominance and distribution of the opacities is important in driving a clever differential diagnosis. I'm sure you have noticed that the opacities on each side are more confluent around the hyla, what we call a central distribution. This central distribution of bilateral airspace opacities is also known as a bat wing appearance. The most common reason to see a bat wing appearance is that of pulmonary edema. Although many other causes could give you what looks like a bat wing appearance, if this appears acutely, two other differentials should be mentioned. If the patient presents with hemoptysis and dropping hemoglobin, this could be pulmonary hemorrhage, and many diseases could be associated with such a condition. And if the patient is immune compromised, especially HIV patients, this could be pneumocystis pneumonia. For juniors who are reading about this, the new name for pneumocystis pneumonia is pneumocystis jirovecii pneumonia, so PJP instead of PCP. I'm sure you've noticed that the right hemidiaphragm is well seen, has a dome-shaped appearance, and a preserved costophrenic angle. This is compared to an obscured left hemidiaphragm by this opacity that has a meniscus appearance and that obliterates the left costophrenic angle. This is consistent with a left pleural effusion. So going with what's common, the diagnosis here was pulmonary edema with a left pleural effusion, and that was fitting with the clinical presentation as well. One imaging hint to pulmonary edema is that it resolves quickly, and this is the patient's follow-up chest X-ray after treatment. So in this case, we talked a bit about the appearance of airspace opacities. We also learned about the bat wing pattern. This could be acute or chronic and in immune competent or immune compromised patients, but the most common would be edema, hemorrhage, and PCP. We also learned that a pleural effusion obscures the hemidiaphragm in what appears like a meniscus, and it also blunts the costophrenic angle. Thank you for watching this case. Your feedback is always appreciated. See you later. Here's a quick one for today. This is a normal chest X-ray, and the question is, what do you think this structure represents? Now, this lateral chest radiograph shows this opacity here, which represents the cardiac shadow, and that's easy. What many people would not have noticed is this opacity here, and if noticed, this may be mistaken for abnormality. Note how this structure extends from below the diaphragm and goes all the way up to the heart. So think about your normal anatomy. What's a structure that could do that? Thinking about it in that way, you probably have guessed it by now. This is the inferior vena cava ascending from the abdomen to reach the right atrium of the heart. And yes, you could see the IVC on a lateral radiograph. So this was a quick one, seeing a normal IVC on a lateral chest radiograph. Thanks for watching. The clear abnormality here are those striking lines that are more pronounced in the lower lungs. Compare that to the upper lungs where you don't see any lines. The only thing that you see are the normal vascular structures. These abnormal lines represent thickening of the interstitium, and the interstitium is the normal connective tissue that holds the lung. If you see those on chest x-rays, this is what we used to call curly B lines. On a CT scan, we call these septae or septations. On a normal CT scan of the chest, such as what we see in the upper lung, you don't see these septations. You might see one or two thin ones. Once the septum is this thick and the number of visualized septations is more pronounced, this is abnormal. It is abnormal to the extent that it delineates these geometric structures, which we call the pulmonary lobules. Each pulmonary lobule is the smallest unit forming the lung, and that's what we in radiology and what pathologists would try to look for. When you see thickening of the septations, you should divide that into either smooth thickening, nodular thickening, or irregular thickening. Since the thickening here is very smooth, we're going to concentrate today on how to approach smooth septal thickening. Once you see this, decide if what you're looking at is acute or chronic. If you have acute septal thickening, the most common reason for that would be cardiogenic or non-cardiogenic pulmonary edema. Another acute reason for smooth septal thickening would be infection, and by that we mean atypical pneumonias. A third reason to give you smooth interlobular septal thickening acutely would be that of pulmonary hemorrhage. To be more accurate, pulmonary hemorrhage starts as airspace opacities, consolidations, or ground glass, and then the blood gets resorbed into the septations, which appear thickened at that time. So it's actually subacute about 3-4 days after the event. A final cause for acute smooth septal thickening would be eosinophilic pneumonia, which is exceedingly rare. Eosinophilic pneumonia in the back of your mind, you'd mention that if there is any supportive history, such as eosinophilia in the blood or in the lungs. How about if this appearance is chronic? There are several possibilities, but the most important would be lymphangitic carcinomatosis. Lymphangitic carcinomatosis is a term applied to metastatic disease that involves the lymphatics that live within the septations. To summarize, part of the backbone of the lung are these connective tissue septations. Septations within the lung are usually not seen or seen with difficulty. If they are clearly thickened, that's abnormal. Divide the thickening into smooth, nodular, or irregular septal thickening. The smallest building unit of the lung is called a pulmonary lobule. If you have smooth septal thickening, it could be acute or chronic. If it's acute, think about edema, hemorrhage, atypical pneumonia, and eosinophilic pneumonia. When this appearance is chronic, there are many causes. The most important would be lymphangitic carcinomatosis. Before I leave, this was a case of pulmonary edema. The clinical scenario was fitting with this diagnosis, and the lower lung distribution supports that. In the case of pulmonary edema, due to fluid within the lungs, fluid would go more to the gravity-dependent areas, and that's why lower lung changes are more common with that.